Tom asked me to update the results of this single-center series of robotic-assisted partial prostatectomy for anterior cancer. So the concept was designed with Indy Gill and his colleagues 12 years ago, and this is when we started this this series. So briefly, it has been published in 2017. This concept is to treat this anterior cancer anterior to the TZ in the AFMS, which are well depicted at MRI. So this is a kind of cases we selected with our radiologist and pathologist. So they should be right anterior to the TZ in a large gland with some mostly on the midline. The rest of the prostate should be free of cancer at systematic biopsies. So this was based on extensive work on radical prostatectomy and cystectomy specimen, where this concept of anterior cancer was described, and some of these could be good candidates for this partial treatment. Do you see that at 2 to 4 cc and even 1 to 2 cc, most of these anterior cancer, they will grow from apex to bladder neck. They will usually we see them on an actual sections, but these are the rationale of the true limits at pathology and not at MRI. Okay, so selection. I mean, among these 20% anterior cancer, every year in my center we have 1 or 2 which could be included in this series. They should be isolated within the AFMS without PZ cancer. I mean, we can do also with one small foci of very low risk associated second cancer. Briefly, the technique which has been described, Okay, so the technique, I do a radical robotic-assisted transperineal like radical prostatectomy. The first step is to cut the DVC and the half of the anterior urethra, distal urethra, only the half part, and then I follow this posterior wall of distal urethra, distal to verimontanum, which will stay there, and everything above that plane and should be removed. And the second part is to do like a partial, simple prostatectomy in this enucleation plane and to join the two. At the end, we'll have the PZ like this, with the verimontanum, the intact posterior wall of the urethra, and then I pull the bladder neck to the urethra and I close the bladder neck to the PZ and urethra borders. Okay, so this is what we have at pathology. So you see the cancer area at MRI, what we see on the gross specimen, and at pathology. Pathology showed in every case a large underestimation of what we had at MRI. Okay, so a few slides for this updated series. So the median follow-up is 65 months. So far, we did 24 patients, 1 to 2 per year. So these are the patient characteristics. Pre-op PSA can be elevated because of this BPH associated, and so most of the cases were diagnosed after 2 series of biopsy due to the location. And you see that the maximum cancer core length for targeted biopsies is 8 millimeter median. So we had half 3+3 and half 3+4. So whole gland volume was 45. Tumor location, I told you, AFMS, midline mostly. The margins were, okay, I'll come back to that. Yes, cancer volume at MRI 2.2 and at pathology 5.3. So this is the real natural history or underestimation of this anterior cancer we see, and we try to treat focally. So yeah, the positive margins, the anterior one depends on whether you leave the fat in front of the tumor, so it's same rate as radical prostatectomy. But the one I was interested in were the posterolateral because of this underestimation. And so I had 5 with an 8 millimeter posterolateral positive margin at pathology, sending the specimen. 4 out of these 5 recurred. Postoperative PSA nadir, median is 0.4, and functional results similar as simple prostatectomy, and per protocol MRI at 12 months and PSA every 6 months. So this is the Kaplan-Meier radical treatment-free survival curve, which is superposable to the clinically significant cancer recurrence, free recurrence survival curve. So at 7 years of, we had a 73% recurrence. So I did 4 radical prostatectomy for 4 recurrences. This is the only thing I had to do. That was a deal with the patient. And as I showed you, the entire posterior aspect of the prostate and neurovascular bundle were left intact. So that was the way to do it. So it's a rare indication, reversible, to prostatectomy. The 4 radical patients are doing well, with undetectable PSA and good continence. And this is like proof to concept or rational study for rational for treatment, partial treatment of this anterior cancer, and I'm happy to share that with you today. Thank you.
Thank you.